Assalamualaikum and a very good morning to everyone. Welcome to this session. I'm sorry for the late start. We had technical difficulties with the IT part. Okay. My name is Rusmawati Muhammad, and co-chairing this session with me is Dr. Farda Akil from Indonesia. So what you can see from the program that we have predominant women as speakers here. It was not supposed to be like that. But we actually had someone pulling out last minute now, and I'm replacing the person. So we will actually get right on to it, and I would like to invite the first speaker for this morning, Dr. Farda Akil herself. And Dr. Farda is actually a consultant, hepatologist, and gastroenterologist at the Hasanuddin University in Makassar. And Dr. Farda will be talking on women and alcoholic liver disease. Please welcome Dr. Farda.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, all of dear colleagues here. Thank you for your coming into this symposium about the woman in hepatologists. But I think I really expecting about the more women here, but I saw some of the men already have been here too. Thank you for your consideration. My topic about the woman and alcoholic liver disease. I should be a replacement for the initial speaker, actually. So nearly half of the global burden of the liver disease, is associated with excessive alcohol consumption. As we've seen here, in the past 10 years, we saw the consumption rate increase in women and also in alcoholic cirrhosis in women. Differences in drinking patterns and alcoholic consumption volume are responsible in the variation in ELD epidemiology between the Asia-Pacific region and the Western
Sorry,
country.
Dr. Farda, I think we need to put a slideshow.
Sorry. This is already in my slideshow here, display. I don't know why.
Okay. Can we have assistance, please, for the slideshow?
In my monitor already in the slideshow. Please, where is the IT here? Okay, thank you. So, according to the WHO patterns of drinking score, this is a composite measure of drinking patterns which reflects how people drink instead of how much they drink. On the scale of 1, it's a least risky pattern of drinking, to 5, the riskiest patterns of drinking. Eastern Europe had a highest patterns of drinking score is 4.9, whereas the score for the United States was 2. It's the same as in China, Japan, and Singapore. In India, South Korea, Malaysia, Philippines, Thailand, and Indonesia, Laos, and Cambodia, the moderate risky pattern was we found in this country. Increased level of alcohol consumption may have contributed to the age-standardized incidence of liver cancer between 2006 and 2016 in the Asia-Pacific region. As we've seen here, all of the region in the country in Asia-Pacific has a higher change in ESR, and the most higher we can find in East Asia, including in China, North Korea, and Taiwan. This is the the cause of the higher incidence of liver cancers is because of the relative deficiency of aldehyde dehydrogenase mitochondria or ALDH2 in Asian population may aggravate liver damage induced by alcohol toxicity. As data from World Health Organization in 2011, we can see the proportion of death and disability adjust life years by alcohol in globally and within Europe. Women is contribute in the proportion of alcohol attribute according to the disability adjusted life years in Europe and in globally. And in general, the risk of liver disease increases with the quantity and the duration of alcohol intake. The quantity of alcohol in alcohol beverage varies by volume based on the type of beverage. The containing approximately 14 grams of pure alcohol is the standard drinks according to the National Institute of Alcohol Abuse and Alcoholism. The type of alcohol consumed vary according to geography. This we can see in here. Spirit like a gin, rum, tequila, vodka, whiskey made up about 45% of global alcohol consumption and were highest in the Southeast Asia region, about 88% of total consumption. The Western Pacific, about 59%, and the Middle East and Eastern Mediterranean region is 48%. As we've seen here, there is a different kind of the amount and the range of the alcohol according to the region in the Europe or United States and Asia Pacific here. Reasons for this global variation are complex and include demographic, religion, and cultural factors as well as economic development level. The prevalence of alcohol liver disease is difficult to define because of it is influenced by many factors, including genetic, such as predilection to alcohol abuse, gender, and environmental factors such as availability of alcohol, social acceptability of alcohol use, concomitant hepatotoxic insult factors. As we've seen here, in the past, prevalence of alcohol consumption was found in the middle-aged and elderly men, but now in the United Kingdom data, in about 1970, the ratio men to woman is about 5 compared to 1, was increased in 1970 to 1980, about 2 compared 1. In Japan, in 2002, there is increased consumption of alcohol, about 16.5% in women compared to men. The increased alcohol use by women worldwide is about because of the social drinking among the young, particularly in women. In female drinkers, we can find a 2 to 4-fold greater risk of ELD than men, and easily to have acute liver failure, and as much as less than 20 grams per day had clinically significant liver disease. The general component in the pathogenesis of alcohol-related liver disease, including increased gut permeability and endotoxin translocation in the liver, inflammatory cell activation, and direct effect of alcohol on the hepatocyte are common between men and women. However, experimental evidence and clinical evidence suggest that there are additional specific changes in women that attribute to the increase of the alcoholic liver disease. So the first is there is a different pattern in hepatocyte cytochrome enzyme metabolism in 2E1 in women, and alcoholic dehydrogenase enzyme in the hepatocyte that have a higher responsiveness in the woman. Second, the gastro activity of alcoholic dehydration is decreased in women. And another, there is a higher response activity of a cell cover in the cell and inflammation that responsive in the lipopolysaccharide because of the high estrogen that found in the hepatocyte. And there is a higher endotoxin too that can found a very stable and sustained level in the woman. This is the clinical manifestation that we can find in alcoholic liver disease. There is a three type of the alcoholic liver disease. There is a liver steatosis, alcoholic hepatitis, and cirrhosis alcoholic. The clinical manifestation about the fatty liver disease occur after acute alcohol ingestion and is generally reversible with the abstinence. Fatty liver is not believed to predispose a patient to any chronic form of the liver disease if abstinence or moderation is maintained. Alcoholic hepatitis is an acute form of induced liver injury that occur with the consumption of the large quantity of alcohol over a prolonged period. In this clinical manifestation of cirrhosis, mortality increased the most in the younger age. Women with cirrhosis that have a daily alcohol intake less than a man already have a cirrhosis, with the duration is less shorter than in men. And progression to liver fibrosis persists even after the abstinence of the alcohol. This is the sign and symptoms for the type of the alcoholic liver disease from fatty liver, alcoholic hepatitis, and alcoholic cirrhosis. But actually the sign and symptoms already have appeared. Only we can found, especially in alcoholic hepatitis and alcoholic cirrhosis, if already the ELD patient come to that stage. About the physical examination and laboratory finding, this is two more can we found if the patient already in alcoholic hepatitis or in the liver alcoholic cirrhosis. The diagnosis of ELD is depending on the history, physical examination, and review of laboratory tests. The definition of alcoholic hepatitis that defined in the Alcoholic Hepatitis Consortium is including the history and the laboratory and the obvious cause of hepatitis should be excluded. The liver biopsy still can use to establish the diagnosis. This is the treatment of alcoholic liver disease from their target, method, and characteristic. Abstinent nutrition support, corticosteroid, pentoxifylline have a potential benefit in the treatment for the survival of patient alcoholic liver disease. The target treatment for ELD is already not confirmed because of they need a further study. There are many potential targets to treat ELD, including the gut microbiota, liver inflammation, regeneration, cell death, and oxidative stress. Several of them are being studied as we shown here in the picture. This is the proposed algorithm for the treatment of alcoholic hepatitis. When we choose patient with alcoholic liver disease, already we have a history, laboratory data, and physical examination. A non-invasive diagnostic test can be used, such as ultrasonography, EST tests, or carbohydrate deficient transferrin, or elastography. Or we can use liver biopsy through all the etiology to determine the severity of the disease or the ELD already in the stage of alcoholic liver or the liver cirrhosis. And then we go to the psychiatry evaluation. There is a group and supportive psychotherapy to promote abstinence from alcohol. If already failure, the pharmacology therapy to alcoholism can be used to this patient. If the success, there should be considered to antifibrogenic therapy like losartan or pentoxifylline. The scoring system for alcoholic hepatitis there is a Madrid discriminant function model for end-stage score and Glasgow alcoholic hepatitis score. This is used to know the severity of alcoholic hepatitis. The Lilly model is one of the scoring system to judge response therapy for corticosteroid in ELD. This is the proposed algorithm for the treatment of alcoholic hepatitis that use the prognosis scoring system before. So if already patient have alcoholic hepatitis, severity stratification using the scoring Madrid or MEL score or Glasgow, and then we go to determine the risk, intermediate or high risk. If they're with severe infection, we can use pentoxifylline about 400 milligrams 3 times daily for 4 weeks. If the patient have no infection or in control infection, corticosteroid can be used at prednisolone 40 milligrams a day. In corticosteroid here, we use a Lilly model score for 7 days in the corticosteroid. If the score is less than 0.45, 4-week corticosteroid can be continue followed by 2 weeks tapering. But if the scoring more and less than 0.45, the corticosteroids should be stopped and should be go to the consider another treatment. If the patient in the low risk after the severity stratification, nutrition assessment and supportive care was used in this patient. For prevention and screening in ELD is to know the alcohol abuse or dependency alcohol. This we can call the alcoholic use disorder. The preferred screening tool that we already use always is the CAC questionnaire. This is have a sensitivity 71% and 95% specificity for alcohol dependency and audit C questionnaire. We can see here the CAC questionnaire. It's a content of 4 questionnaire here, and this is a audit C questionnaire. Audit C questionnaire have a probability dependence for their score more than 9. It's about 42%, and they can divide it about for the low risk, hazardous or harmful range or alcohol dependent range that they need the separate treatment for this range. Another new pathomechanism that stress pathophysiology may be an important direction to develop tailored treatment for women. So overall, women are generally more likely to drink to regulate negative effect and stress reactivity, as we saw in this scheme as a negative reinforcement actually mostly can be found in the woman. And in here, a probing stress pathophysiology with reflex sex difference in neurological underpinning could be one of the treatment in the target for alcoholic use disorder. This is one study that used a brain system to know how the effect of alcohol in the stress physiology. As they saw here, that targeting brain stress system like noradrenergic agent, corticotropin releasing factor antagonists, kappa opioid receptor antagonists and GABA-energic agents have been shown to reduce alcohol self-administration, especially in the woman. As a conclusion, education of women is pivotal to raise awareness of the increased risk and harmful effect of chronic and excessive alcohol use on the liver in the woman. The absolutely safe amount of alcohol may vary depending on each individual genetic and other factors. Women should be limit consumption of alcohol to 14 grams or 1 drink a day and have at least 2 alcohol-free days each week to avoid ELD. In clinical practice, there is no difference in clinical management of ELD and alcoholic hepatitis between men and women. Thank you for your kind attention.
Thank you very much, Dr. Farda, for a very comprehensive overview on the effect of alcohol, particularly in women. So it gives me great pleasure. We will actually have the questions at the end after the third speaker. So it gives me great pleasure to introduce the next speaker, Professor Grace Wong from the Chinese University of Hong Kong. Grace actually is no stranger to the audience at APASO. She has won numerous awards, including a previous Young Investigator at APASO and the most recent, the Sir David Todd Lectureship from the Hong Kong Academy of Medicine. So Grace, this morning, will actually talk about fatty liver in pregnancy, approach and management. Grace?
Thank you. Thank you, Professor Rose, for a very kind introduction. Good morning, ladies and gentlemen. I really appreciate your presence and attendance to this very important meeting. So I would like to share with you a very important topic that can be quite common that we encounter in our clinical practice. So these are my disclosures. In fact, this topic would be a big topic in the sense that because it can be as common as novelty in a lady who is just happened to be pregnant, or something rare but very important would be acute fatty liver of pregnancy. So I will start with the rarer but more important topic first. So if you have been consulted by obstetrician, you may encounter such as critical scenario maybe once or twice a year, because this is a rare but life-threatening condition that it is characterized by microvesicular fatty infiltration of the liver, causing acute liver failure in a pregnant lady. There will be concomitant preeclampsia, and that happened roughly in 50% of the pregnant lady, and the median gestation age at the time of identification would be around 36 weeks. So most of the time would be mid of the third trimester. So the risk factors of this very important condition include previous attack of acute fatty liver pregnancy, concomitant conditions complicating pregnancy like preeclampsia, HELLP syndrome, twin pregnancy, male gender of the fetus, or in some extreme body mass index like below 20. In fact, the presentation of this important condition can be rather non-specific. The lady may just present with some nausea, vomiting, which could happen in the earlier stage of pregnancy. But if it happened in the late stage, then we need to be very alert. And they will have quite bad abdominal pain. If some of the audience have been pregnant, in fact, abdominal pain is not rare in a pregnant lady, but it would be more localized in the right upper quadrant. And the striking feature would be very high transaminase levels, as well as raised bilirubin. The transaminase can be as high as a few thousand. And there may be hepatic decompensation, including encephalopathy, coagulopathy, hypocalcemia, and these all pointing towards to be a very bad condition, situation. And other complications like renal dysfunction as well as pancreatitis will also happen. Again, these are the worst prognostic factors. So how can we diagnose this situation? In fact, it's mainly based on clinical as well as laboratory parameters. So there would be a list of clinical or imaging or pathological factors that you can consider, as well as other important laboratory abnormalities, including raised bilirubin. offered to the woman with such a condition as well as to her offsprings. And close monitoring for the manifestation of this LCHAD deficiency, like other manifestations including hypoketotic hypoglycemia or fatty liver, should be considered again to the offsprings of the affected mothers. So I also listed up other conditions that may complicate pregnancy, because the lady would not come to tell you that, oh, I have acute fatty liver pregnancy. In fact, they were presented with something that, in fact, you will appreciate it overlap quite a lot. But the most important thing is the time of onset. It is always third trimester. And in fact, it is rare, but it can be, it would be life-threatening. And in terms of the clinical manifestation, the features will include more bad, like decompensating features like coagulopathy, encephalopathy, hyperglycemia, renal dysfunction, and pancreatitis. And the accident is immediate delivery. And please note that, in fact, this condition also may overlap with like preeclampsia and HELLP syndrome, so some of the features may coexist. Okay, now may I move on to the next big topic, would be NAFLD in a pregnant lady. In this meeting, there have been a few important sessions covering NAFLD. So I will have more focused discussion on this situation in a pregnant lady. So we all understand this is an important disease, very common, as well as can lead to a lot of complications. And the prevalence in our region can be as high as 30 to 40%. And in fact, there has been recent updates in terms of the definition, risk factors, assessment, management. So I think these two nice review articles will warrant some in-depth reading if you're interested. And in this recent update, we know about this situation has been becoming more common in our region. And we also understand the natural history better. And we can make use of more non-invasive tests to diagnose that, and as well as to for risk stratification. And we also have more drugs to treat this condition. But how about this situation in pregnancy? We know that pregnant ladies, usually they are not as old. They may be in their like 20s, 30s, or almost 40s. So in fact, the prevalence of this condition is childbearing age women would be roughly around 10%. And there's been no evidence saying that pregnancy will increase the risk of NAFLD. So this just happened to be coexist. And for diagnosis, we can make use of some simple tests like ultrasound scan, some simple blood tests like the transamylase level. We may also make use of other non-invasive biomarkers like the fatty liver index, FIB-4 or ELF score for fibrosis. In fact, transient elastography has been mentioned as contraindicated in pregnancy. However, I also encountered a few studies have been using this tool in a pregnant lady. Usually it's during first or second trimester. In fact, it has been reported to be quite well. But personally, I would still prefer to delay this examination to be after the delivery, because most of the time there will be no hurry at all to really perform transient elastography. And in terms of the pregnancy outcomes, in fact, there will be some negative impact of NAFLD on pregnancy, because it will increase the risk of preeclampsia for around 6 to 7 times. Infants large for gestational age is around 4 times risk, as well as some increased risk of preterm delivery. And in fact, there would be bidirectional association between gestational diabetes mellitus as well as NAFLD. So the odds ratio is around 2 to 4 times. And if NAFLD is present as the first trimester, in fact, this is an independent risk factors for gestational diabetes. And in terms of the infants, in fact, most of the time there will be some problem if the mother has NAFLD. So maternal NAFLD increases the risk of future disease in her offspring. For example, they will be large for gestational age. Infants born small for gestational stage are also increase the risk to have future NAFLD when they have grown up. So both under and over nourishment in uterine could prime the development of NAFLD in children. So this graph showing how interactive it is between maternal NAFLD as well as other epigenetic changes, as well as the type 2 diabetes mellitus. So it's so interrelated, not just affecting the mother, but also affecting the children in the future. And this can be a cycle that may happen to another generation and generation. So in fact, it would be quite nice to prevent NAFLD to presence before pregnancy. So Because during pregnancy, it's quite unlikely to start any pharmacological treatment, so most of the time we will recommend some dietary restriction during pregnancy. So probably you know that most of the mother would want to get more nutrition to make the baby more healthier, but we should also be very cautious about like the calorie intakes as well as other macronutritional component. For example, we should limit the calorie intake for at around 1,800 kilocal per day, or even slightly less than that. And for the macronutrient composition, so we need to have a bit more carbohydrates, proteins, fiber, and try to have only low to moderate fat intake. And we should avoid fructose as well as alcohol. In terms of coffee, in fact, there's no restriction in terms of liver size. In fact, caffeine has been shown to be good in terms of reducing liver fibrosis as well as reducing liver cancer. So in conclusion, Chairman, ladies and gentlemen, I hope this very precise review will help you to understand fatty liver in pregnancy more. In fact, there will be two distinct conditions. So acute fatty liver pregnancy, something quite rare but very important, life-threatening. So always consider prompt delivery or termination of pregnancy to save the mother and baby. And NAFLD in pregnant lady is common, is up to 10%. Always remember it is closely associated with gestational diabetes mellitus, and it may have negative impacts in terms of the pregnancy as well as the infant as well as their future after growing up. So a good dietary control would be good, as well as to prevent NAFLD before pregnancy would be nice. So with that, I thank you very much. I also like to spend 1 minute to invite you all to Hong Kong in August, that we have our 10th anniversary of the International Digestive Disease Forum, IDDF. We welcome abstract submission as well as case report video. We have Young Investigator Award. The winner will get $3,000 as the prize. And for the case and video, we also have 3 champions with $500 each. So with that, I thank you very much for your attention.
Thank you very much, Dr. Grace, for your nice speaking and complete. Next, we go to the third and the last speaker, Dr. Rosmawati Muhammad from Malaysia. Is a professor from Department of Medicine, University Malaya since 2030, and consultant hepatologist in University Malaya Medical Center since 1998. Dr. Rosmawati is a co-chair of CHEF-HEP. CHEF-HEP is a coalition to eradicate viral hepatitis in Asia Pacific and an executive committee of Basel. Please take your time, Dr. Ross.
Thank you, Dr. Farda, for the very kind introduction. A very good morning, everyone. So what I would like to start with is just trying to think about the impact of hepatitis B in pregnancy. So in general, we actually say that pregnancy is not impacted by the chronic hepatitis B infection, and pregnancy per se does not seem to worsen the underlying liver disease. However, from the baby's perspective, it is well known that the risk of chronicity is very much dependent on the age when the infection occurs. So this figure looks at the outcome of hepatitis B by the age of infection. So the risk of chronicity is up to 90% if it occurs at birth, and also much lower in older children to less than 5%, and also the same in adults. So it is actually known for a long time now that, and it's recommended that babies born to chronic hepatitis B mothers should receive both passive immunization with hepatitis B immunoglobulin and the first dose of hepatitis B vaccine within 12 hours of delivery. So let's look at what AASLD state on this prevention of hepatitis B. And what it has stressed is that the HBIG and hepatitis B vaccination to the newborn given immediately after delivery is the best preventive measure for prevention of mother-to-child transmission of hepatitis B. However, despite the passive and active immunization at birth, up to 20% of babies have the risk of actually getting infected. So what the ASOD recommend is that pregnant women should be tested for HBs antigen, and those positive should be actually delivered in the healthcare setting so that the babies can have timely dose of hepatitis B vaccine to prevent transmission of hepatitis B. Now, similarly, the EASL guideline strongly recommend screening for HBsAg in the first trimester of pregnancy. And the management of HBs antigen will depend very much on the underlying severity of liver disease, and we'll come back to this later. First, let's look at the risk of the mother-to-child transmission of hepatitis B. So several studies have shown that the maternal hepatitis B DNA level is an independent risk factor for perinatal transmission. So in this study shown here on your right, despite receiving birth dose and subsequent 2 doses of hepatitis B vaccination, the immunoprophylaxis failure is actually overall 4.9%. And you can see in the graph is that the risk increases with increasing DNA level. So in this study, it's shown that the perinatal transmission of hepatitis B was 2.9% infants who are born to HBV DNA positive women, and is more than 2-fold higher if the mothers are E antigen positive, and the rate was 6.6%. And interestingly, in this study, it showed that there was no transmission of hepatitis B when the maternal hepatitis B DNA is less than 8 log, but if it's actually more than 8 log copies per mil, so this was actually done years ago, so they're using copies per mil, the risk of transmission to the babies is 8.5%. So this is a systematic review, included 26 studies and more than 3,600 pregnant women evaluating the use of antiviral therapy in addition to standard HBIG and vaccination to the infants for mothers who are hepatitis B positive during pregnancy. So compared to the control group, those receiving antiviral therapy had a reduced risk of surface antigen seropositivity of the infants by 13.4% and reduction of DNA positivity by 18.7%. So from the perspective of the fetus, there were no statistically significant difference on the congenital malformation, the prematurity rate, as well as the UPGAR scores at birth. From the mother's perspective, there was no statistically significant difference in the rates of postpartum hemorrhage, cesarean section, and also elevated creatinine kinase level. So the authors conclude that the antiviral therapy did improve the hepatitis B suppression and therefore reduces the mother-to-child transmission in women with chronic hepatitis B infection with high viral load compared to just HBIG and vaccination alone in the infants. What about the choice of antiviral therapy? So when we looked at this graph, this is actually, this slide, it shows the antiviral options for hepatitis B according to the pregnancy category, and I think we all know that category B medications include tenofovir and telbuvidine, and classified as such because the animal reproduction studies have failed to demonstrate risk to the fetus, and there are no adequate and well-controlled studies in pregnant women. So the others are actually classified as category C and should be used with caution if it really the benefits outweigh the risk. So in this study, it evaluated the use of tenofovir to prevent hepatitis B transmission in mothers with high viral load. And this study, the high viral load, is actually defined as HBV DNA of more than 200,000. So the treatment group received tenofovir 300 milligrams daily from week 30 to 32 up to postpartum week 4, compared to the standard of care given for the other group with no antiviral therapy. And you can see clearly on the left that those who received tenofovir actually has a much lower rate of infants being hepatitis B positive compared to the group on the right with standard of care. And you can see that the per protocol analysis showed that zero transmission in those who received tenofovir compared to 7% in those with usual care and no antiviral therapy. So in the EASL guidelines, it actually stated on the management is very much dependent on the severity of liver disease. So EASL recommend, or rather strongly recommend, treatment only if the mothers have advanced fibrosis or cirrhosis, or if the pregnant woman have DNA greater than 200,000 IU per ml, and they use another marker of surface antigen more than 4 log IU per ml. And the antiviral prophylaxis for choice is tenofovir, and this should be started at week 24 to 28 of gestation, and continue for a bit longer than the other studies, up to 12 weeks after delivery. So grade 1 evidence and recommendation for that. Note that breastfeeding is not contraindicated in surface antigen positive mothers, or even if they are on treatment. So this is the AASLD guidance statements in regards to hepatitis B in pregnancy, and it's recommended that HBs antigen positive women should be really evaluated closely and linked to care, needing additional testing like the usual ALT, DNA level to determine the need of antiviral therapy. And here, AASLD mentioned that women who meet standard indications for hepatitis B therapy, if they have active disease from the forms of the virus and the liver, then they should be started on treatment whenever that's been detected. It's not restricted to the 3rd trimester. And women without standard indication who have DNA more than 200,000 IU per ml should be considered for treatment to reduce the mother-to-child transmission of hepatitis B. So tenofovir is the preferred option, and here it says to be started in the 3rd trimester and to discontinue the antiviral therapy at birth to 4 weeks postpartum. And it's also recommended that the monitoring for ALT flares is actually should be every 3 months for 6 months after stopping antiviral therapy. And lastly, again, breastfeeding is not contraindicated. So let's look at this monitoring for ALT flares. And it's known, even without antiviral therapy, that the risk of hepatitis flare can occur after delivery, and up to 25% of women have hepatitis flare within the first few months post-delivery. And in fact, it may not be a bad thing for some of these women because e-antigen seroconversion rates, have been reported, up to 17% have been described, the e-antigen seroconversion rate post-delivery. And it's been postulated that the reason for this is because of the rapid reduction in the cortisol level postpartum, and that is really analogous to actually having steroid withdrawal therapy, and that has been previously used in the old days to elicit seroconversion, hardly used these days, of course. And the flares, fortunately, that occur post-delivery are most likely going to be mild, and they do resolve spontaneously, but then cases of acute liver failure have been described, and most of them have had the reason being that these patients have underlying advanced fibrosis or cirrhosis. Now, this study looked at extending the antiviral therapy from the 3rd trimester to 2 to 12 weeks postpartum. And what it has shown that the extending the antiviral therapy to up to 12 weeks did not protect against the postpartum flares, so supporting the ASLD guideline recommendation that it can be stopped at delivery or up to 4 weeks postpartum. So this table gives a summary of the existing guidance and recommendations for prevention of mother-to-child transmission of hepatitis B. So you can see from the 3 columns that there are slight differences in the treatment eligibility, the timing of antiviral therapy, as well as the treatment option for the maternal antivirus given for prevention of mother-to-child transmission of hepatitis B. But in general, you can actually suffice to say that it should be started for those with high viral load, and most will accept that HBV DNA more than 200,000 IU per mil is considered high viral load. And these women who have surface antigen positive should receive the antiviral therapy during the 3rd trimester and should be continued at least until delivery, up to 4 to 12 weeks post-delivery. So antenatal testing, I must add, and actually we have to bear in mind that most likely this will be given outside, or this will be done outside the hospital's testing, and mainly at the primary care or the maternity centers. So when we do that, we need to think about decentralizing as well as simplifying testing treatment of hepatitis B in pregnancy. So for that, we need to simplify the management algorithm of chronic hepatitis B mothers in pregnancy. So this is a proposed simplified test and treat algorithm for surface antigen positive pregnant mothers. The first step, of course, is to test for the surface antigen. And for the purpose of decentralization, a rapid test for S antigen is preferred. There's now even available a rapid test for E antigen. That's just recently available. And you can do that so that you can automatically know in a resource-limited setting, E antigen positivity usually means a very high DNA level of more than 7 log IU per mil. So if the person is S antigen positive, another simplification is to do reflex testing for E antigen with or without DNA level to assess the activity of the virus. And the next step would be assessing the liver disease activity. So to simplify things, we would say that treatment is indicated when there is disease activity with or without cirrhosis. And the definition that I have put here, it actually follows very much the EASA guidelines. So for cirrhosis, it depends on for cirrhosis, any detectable DNA should be considered for treatment. For those without cirrhosis, the DNA of greater than 2,000 IU per mil plus ALT more than upper limit of normal and/or with at least significant fibrosis is considered to have disease activity and should be considered for treatment. So with those without any signs of disease activity, then if they are E antigen positive or have a DNA of greater than 200,000 IU per mil, then treatment should be considered. And should start with tenofovir from week 30 to 32 weeks of gestation, and discontinue at birth or up to 1 to 3 months post-delivery. So we do need to consider the risk of hepatitis B flare. So this, after delivery, is actually recommended to monitor ALT 3 and 6 months after delivery. So let's look at prevention of mother-to-child transmission of hepatitis B as part of the whole bigger picture of hepatitis B elimination. And we're all very familiar with the global health sector strategy for viral hepatitis, which provides a clear roadmap to achieving hepatitis B elimination. And the ultimate goal is to eliminate viral hepatitis as a major public health threat by the year 2030. So most of us are very familiar with the targets that's been set. And this is really to get governments to really move towards getting, or rather achieving these targets. But a lot of people are not so familiar about the targets at the 2020, this year. The interim targets actually really will help countries to actually report on their progress on the hepatitis response, and in terms of incident, reducing the new cases by 30% and deaths by 10% by this year. So these are the service targets included in the global strategy. And you can see I will be focusing mainly on those related directly on hepatitis B. And you can see for 2020, the 3-dose hepatitis B vaccination target is actually a coverage of 90%, and for the birth dose of hepatitis B vaccination of 50%. And this is actually a report card, this last column from the Western Pacific region on the elimination. And you can see here clearly on the vaccination, the prevention is on track. But at the bottom there, testing and treatment for hepatitis B is not on track, it's below the targets. So when we talked about incidence impact target, that means the reduction, what does it mean? It actually means that if you want to achieve 30% reduction, it's achieving a prevalence of about 1% of S antigen in children, and for the 2030 of 0.1% HBsAg prevalence amongst children. And again, that's related to immunization targets. So let's look at the progress towards hepatitis B control through immunization in the Western Pacific region. And what I would like to highlight is that the Western Pacific region has managed to achieve the target at 2020 because they had this target on hepatitis B vaccination as a EPI pillar right from the turn of this century, and then introduced a target to reduce HBs antigen prevalence to initially less than 2%, and moved the target even further to less than 1% by 2017. Managed to achieve this in 2016. So that is tremendous progress, and what it has shown is that the impact of vaccination is tremendous. It has prevented more than 37 million new hepatitis B infections in the Western Pacific region, saving more than 7 million lives related to hepatitis B. And I think it should be applauded that this has been actually done in the Western Pacific region. However, epidemiological and modeling data have shown that infant hepatitis B vaccination alone, including the timely hepatitis B birth dose, will not be enough to reach the 2030 incidence target of less than 0.1%. So hence, in 2017, WIPRO endorsed another framework, the triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B. So I'm going to go very quickly on this regional framework, and I think what should be stressed, it provides a coordinated approach to the triple elimination of mother-to-child transmission of HIV, hepatitis B, and syphilis through quality services for mothers, their newborn children and families, and in the context of the universal health coverage, and using these 3 pillars shown at the bottom here. So what actually we would like to stress is when we talked about elimination by 2030, it's all about taking things to scale. And that includes substantial expansion of services needed to achieve elimination, particularly on the testing and treatment, which I've shown in the Western Pacific region also are not on track. So the triple elimination provides an important opportunity for synergy, and is also a joint call for high-level commitment on quality maternal, newborn, and child health services. And there are additional benefits. It's not just about for the mothers or the newborn, but it provides an important, the testing itself, it provides an important entry point for diagnosis and care of chronic hepatitis B infection, also for the family members. And in addition, this can potentially build more efficient and sustainable mechanisms and platforms to prevent other infectious diseases prevention, like hepatitis C. So I'm going to be very quick because I think time's up. So what I would like to just say that the triple elimination framework can introduce potentially additional intervention, and this would start with the screening for hepatitis B in the antenatal period. So this is actually the proposed tiered approach to the introduction of comprehensive package of intervention for elimination of mother-to-child transmission of hepatitis B. And what is actually stressed here, it should be built on a strong hepatitis B vaccination program. So when you think about considering antenatal screening to introduce it, you must make sure that the birth dose, timely birth dose and follow-up doses hepatitis B vaccination is already in place and strengthened before you introduce HBIC as well as potential use of the antiviral treatment for the mothers. And so this must continue to be prioritized for this to happen. So to conclude, the management of hepatitis B infection in pregnancy needs to take into consideration the well-being of both the mother as well as the infant. And antenatal testing for hepatitis B is not just aimed at preventing mother-to-child transmission of hepatitis B, but also serves as an early entry point into care and treatment for women, family members, and the partners. And then you can see that currently the decision to treat mothers with antiviral therapy will depend on the severity of the liver disease and also the risk of perinatal transmission. And the current guidelines recommend initiating antiviral therapy during the third trimester when the DNA levels is greater than 200,000 IU per ml. For the babies, the timely administration of hepatitis B vaccine and HBIC are critical to break the chain of perinatal transmission. And lastly, the opportunity for the triple elimination network to accelerate the hepatitis response in the region is there. So with that, thank you.
Thank you very much, Dr. Rosmawati, for your great lecture and complete. Yes, I would like to invite Dr. Grace in the stage here, and we go to the discussion. Okay, is there is a question from the podium? Yes, please.
Thank you. My name is Abdul from Indonesia. And the first question for Dr. Farda Akil. How can we diagnose the acute liver disease? Because the alcoholic liver disease is the chronic disease, but maybe we can know about the history of the patients. He just stopped the drinking for 2 or 3 years but we're not sure this is alcoholic or not. But is there any range of the years that from the patient we can take the history of the past? And then how the importance of microbiota for alcoholic liver disease? And then third question for Dr. Grace. NAFLD is not just associated with metabolic syndrome but also insulin resistance. How we can explain about hypoglycemic states in IFLD in pregnancy? Thank you.
Thank you very much. So, according to the history of alcoholic intake, there is some of history that we can use for a woman. It's 20, maybe about 20 gram less. More than 20 grams a day or more than 70 grams a week for a woman that we can see here that their capability for having a liver disease. Actually, for having acute liver disease for a patient with ELD, mostly patient already in the alcoholic hepatitis can have the acute hepatitis here, and they also already in the sometimes in the very bad condition. They can have decompensation staging because of we did not know if they already having this ELD in the prolonged time. So for the diagnosis for if we just suspect the ELD, we can use a liver biopsy for the patient to have the adjustment of their ELD. And for microbiota, as we've seen here, that in patient with fatty liver disease, there is a gut, alcoholic liver disease, sorry, there is a gut permeability here that the alcohol, ethanol itself, it make differences in the microbiota in the intestine. Some of studies say that enterobacteria have increased in patient with alcoholic liver disease. That we know that this enterobacteria is not a normal microbiota in our intestinal. If their population is higher than the normal population, that can make some of the mechanism like inflammation and endotoxin more increase and go to the liver. Thank you. Dr. Grace?
Yes, thank you for your questions. I hope I get your question right, that you're very right that in fact gestational diabetes, insulin resistance is closely related. We can never tease out two conditions separately. So that's insulin resistance is the major drive for the whole metabolic syndrome, not just diabetes mellitus, but also other metabolic abnormalities. So in pregnancy, I would say that this happens, and also in fact the risk of having worsening of insulin resistance and diabetes probably would be more than in a non-pregnant state. In this condition, in fact, the ladies will still need to have like control of her for example, if she really have diabetes, then good glycemic control is still important to improve her pregnancy outcome as well as to improve the fetus outcome. It's just that because most of the oral hypoglycemic agent may not be appropriate during pregnancy, so very often if they have very bad glycemic control, insulin is still needed in this situation. Thank you.
Is there any question? Or I would like to ask Dr. Dr. Rosmawati? Yeah. Prof? Yes. As you said here, the HB envelope antigen, I think is one of the factors that risk for the MCTC in the mother to child. So, and I saw the data too. It's a more higher risk compared to HBV-DNA. So how we must choose the right maybe prevention or antiviral or something like that to this mother. Thank you.
Okay, thanks, Dr. Farda. I think for a long time, we have been using e-antigen positivity as a surrogate marker to having high viral load. And if you see the EASL guidelines where they had the new nomenclature proposed, it actually did look at studies looking at the viral load of all patients who are e-antigen positive. And you can see that most of these e-antigen positive women, or rather people, will have DNA of more than 7 logs. In fact, that is in general true. The time that the E-positive people will actually have lower viral load is when they have active liver disease, because as the immune system is reacting towards the viral load does come down slightly. So when the ALT is raised during the phase, which I don't like the name, they call it chronic hepatitis B e-antigen positive, I would rather say it is the disease state related to the activity, then your viral load can come down slightly, but it's never very low anyway. Minimum is actually going to still be 20,000.
Yes, because I didn't see in the all of guidelines HbA antigen as a recommended.
I think that is actually something we need to stress in Asia Pacific, because I did put in my proposed algorithm, you can use e-antigen positivity by itself. And that will be the first thing we'll do clinically. In clinical practice, we do that. So if a person is E-negative, that's the time that you want to know what the DNA is, because those patients may actually have high viral load despite having E-negativity. So the conclusion from that is test the E-antigen first. And you can do that even with a rapid test now. And then if you're E-negative, then there's the time that you need to do a more expensive test. Because I know DNA test is going to be very expensive, 10 times more or 20 times more than the E-antigen level.
Yeah. So, Professor Rose, may I also ask about the timing of starting TDF to prevent mother-to-child transmission? Because from time to time, we encounter mother with very high viral load, like 8 logs, even 9 logs. I wonder if we really start at week 30, then may not be sufficient time to bring down the viral load?
You're absolutely right, because I think the studies have shown that you may want to actually start earlier, and I think that is the reason why ESA actually proposed to start at week 24. And that, I think, can be considered if the mothers have high viral load. So yes, I think, Grace, that's a very good point, and that is why the differences in the recommendation. So we put in general 3rd trimester, but if you have the ability to actually have the DNA and saw that the viral load is more than 7 log, you may want to start even earlier.
Is there any question from the, please? One more question.
Thank you. I am Sri Rijiki from Indonesia. I want to ask the Dr. Rosmawati Mohammed regarding to the recommendation of EASL that in all pregnant women must start the prophylaxis from 24 until 28 weeks of pregnancy. My question is, how about we get a case, patient came with gestational more than 28 weeks of pregnancy. Does the prophylaxis treatment is effectively?
Yeah.
Thank you.
Yeah, so that's why some of the guidelines just mentioned 3rd trimester. But in fact, you can actually start as soon as actually, like this person presents at 28 weeks, you can even start even then. The 24 to 28 was actually a rough estimate. Some of the studies did start from week 24. A lot more studies like the PAN started a bit later, between 30 to 32. But I think we have the same view that if the person has got very high viral load, it might take a while for the tenofovir to work, and you may want to consider starting earlier.
Okay. There is another question. Next, please.
Actually, as you know, the Delta only exists with hepatitis B, so the management, I would think, will not be any different from just having hepatitis B alone compared to having hepatitis B and D together. So the same management applies, that you will still start early at the 3rd trimester for these women and continue up to delivery at least. Yes, so it's not different.
May you use, sorry, may you use the
I might not hear you
microphone, please?
Ma'am, my question is that patient in the 3rd trimester, but there's the co-infection B and delta. And what is the treatment protocol for the B and delta in 3rd trimester pregnancy?
I did answer the same. It will not be any different because you will actually really be treating for hepatitis B. So the D will not be transmitted if you actually have prevented the B. So it will be exactly the same. Third trimester, start antiviral treatment and continue.
And other question, ma'am, whenever a patient came in the third trimester, but patient in the advanced stage, child C, and at that stage, what was the treatment protocol for TDF and how long TDF continue after pregnancy?
Okay, so basically the cirrhosis part will be hopefully detected earlier, but even if it's detected only at the time of delivery, I mean at the time of the third trimester, even near delivery time, you should be starting treatment already and continue lifelong.
Like,
Yeah.
okay. Thank you.
Yeah. Yeah. So even so, you mentioned in the chart you see, in the first place, most of these cirrhotics are not so fertile, but if they do actually have CHOP UC during the pregnancy itself, then the treatment, as you know, may take some time to work. So the studies have shown even in the non-pregnant state, the antiviral treatment started for patients with decompensated cirrhosis. It will take up to, to see an effect, it will be at least 6 months sometimes to see whether some of these patients will get better. But whatever it is, you are actually really need to start treatment as soon as possible. Okay, I think time's up. Thank you very much to the speakers. Can we give them applause? And thank you all audience for your great participation. Thank you.
Enjoy your lectures, very comprehensive.
Okay, we want to take a photo together.
Thank you.